I'm Dr. Jamie Caroon, and I'm the Medical Director at the Center for Medical Cannabis Education. In this video, we are going to look at the first randomized controlled trial using cannabidiol, or CBD, to treat cannabis use disorder or addiction to cannabis. This study is entitled Cannabidiol for the Treatment of Cannabis Use Disorder, a Phase 2A double-blind, placebo-controlled, randomized, adaptive Bayesian trial. It was published in the Lancet Psychiatry in July of 2020. It is a Phase 2A randomized controlled trial, which means that it was a pilot study using a relatively small number of subjects in order to judge the efficacy and safety of the investigational drug. It uses an adaptive Bayesian design to estimate the probability of the most efficacious dose of CBD to treat cannabis use disorder. So it was designed to be a dose-finding trial with both efficacy and safety endpoints. The study population was comprised of 82 individuals meeting the DSM-5 criteria for cannabis use disorder, and we'll go over that. The intervention was cannabidiol, or CBD, administered orally in doses of 200, 400, and 800 milligrams over 4 weeks. There were both objective and subjective outcomes. The primary outcomes were the objective measurement of a metabolite of THC in urine and the subjective self-report of any change in the number of days of abstinence from cannabis use. Secondary outcomes were subjective and related to withdrawal, sleep, anxiety, and some other factors. This trial was implemented at the Clinical Pharmacology Unit at the University College in London. A quick review of the background. Cannabis use disorders affect a large number of people worldwide, 22 million, it's estimated. THC is the component in cannabis that causes dose-dependent intoxication. It has rewarding effects, reinforcing effects. Individuals can develop tolerance to THC and can develop cannabis use disorders specific to THC. Despite the substantial and increasing demand for treatment for this condition, very few, if any, pharmacotherapies are currently recommended for cannabis use disorders. CBD itself has shown a therapeutic effect in humans and in preclinical models of addiction, including addiction to cannabis, opioids, and tobacco. Open-label case studies have reported that CBD products are associated with reduced cannabis withdrawal symptoms during abstinence. In some randomized controlled trials, using a combination of THC and CBD in a 1-to-1 ratio, and this is the drug nabiximols, have been found to reduce cannabis withdrawal symptoms and cannabis use, or both. However, in these studies using nabiximols, it's not clear what the role of CBD is because THC and CBD are both ingredients in nabiximols. Finally, no randomized controlled trials have investigated CBD as a potential treatment for cannabis use disorder. Cannabis use disorder is different from dependence. It includes dependence and tolerance, but it is different. It's a criteria-based diagnosis. Dependence itself is the appearance of withdrawal symptoms after cessation, and tolerance is the adaptation of the body to a certain dose of a given substance and a requirement for a higher dose of that substance over time in order to achieve the same effects. The criteria for substance use disorders in the DSM-5 are basically the same regardless of the substance. With regard to the methods, participants were recruited through advertisements on websites, forums, and flyers in the local community. They were randomly assigned to 4 different arms. There were 2 stages to this clinical trial, so participants were randomized at 2 different intervals. The 200 milligram dose of CBD was eliminated after the first interval due to the fact that it lacked efficacy. This study was funded by the UK Medical Research Council. Individuals also had to express a desire to stop using cannabis with an intention to do so in the next month, and they must have reported trying at least once in the past to quit. The study population was mostly male, about 70 to 75%, and the average age was in the mid to late 20s. This is an outline of the study design. Participants attended weekly site visits during the treatment period, which was over 4 weeks, and then follow-up occurred at weeks 6, 8, 12, 16, 20, and 24. And some of those follow-up visits were telephone visits and some were in-person visits. There were 6 30-minute individual sessions of motivational interviewing, which were delivered by trained psychologists. So to be clear, the intervention was more than just CBD, but the placebo group also received the psychological intervention. The study drug was provided by STI Pharmaceuticals, a UK-based pharmaceutical company. It was 99.9% CBD, administered orally in capsule form, and participants took 2 capsules twice daily. So this was not a full-spectrum cannabis extract. It was isolated CBD. And so there's a question as to whether we can extrapolate these findings to full-spectrum cannabis-derived CBD products. With regard to the data analysis, it was a Bayesian analysis that calculated the probability of each dose being efficacious compared to placebo. Both linear and logistic regression models were used. All analyses were conducted on an intention-to-treat basis. 82 individuals were randomized. 77 of them, or 94%, completed the trial and adhered to the treatment during all treatment weeks and attended all treatment week visits within 2 days of the scheduled appointments. Only 5 were lost to follow-up. The primary outcomes were a reduction in the urinary carboxy-THC creatinine ratio. Carboxy-THC is a metabolite of THC. It is inert, and it's often used in urinary drug tests as a surrogate marker for cannabis use. The second primary outcome was an increase in days per week with abstinence from cannabis, or both. There were multiple secondary outcomes, including cannabis withdrawal, tobacco use, cigarettes smoked per self-report, alcohol consumption, sleep quality, depression, and anxiety. This is a depiction of Table 3 from the study. You can see that during treatment, the ratio of carboxy-THC to creatinine decreased by approximately 94 points on average at 400 milligrams of CBD, and that the number of days of abstinence increased by half a day on average. At 800 milligrams of CBD, the ratio of carboxy-THC to creatinine decreased by approximately 72 points on average, and the number of days of abstinence increased by a quarter of a day on average. So during treatment, both doses seem to be effective, but 400 milligrams seems to be more effective for the primary outcomes. This is the same table, but here we see the primary outcomes up to the final follow-up period, so 24 weeks. As you can see, there was a large drop-off in these primary outcomes over time when CBD was no longer being administered. Obviously, there was a large relapse rate in this population after leaving the structure of the clinical trial. A few highlights from the secondary outcomes. The 400 milligram dose did not reduce cannabis withdrawal scores during treatment, and it led to a small decrease in sleep quality, both during and after treatment, almost 1 point on the 20-point Pittsburgh Sleep Quality Index scale. The 800 milligram dose did reduce cannabis withdrawal scores, both during and after treatment. Both of these reductions were by small amounts, 1.25 and 2.5 point reductions, respectively, on the 10-point cannabis withdrawal scale. A decrease of 1.29 points was also noted during treatment on the 7-point Beck Anxiety Inventory. At all 3 different dosages, the number of mild or moderate adverse events was no different than placebo. and there were no severe adverse events reported, and no participants dropped out of the study because of the intervention. With regard to the discussion, the authors state that this was the first randomized clinical trial using CBD to treat individuals with cannabis use disorder, and they concluded that cannabidiol was a safe and efficacious treatment for reducing cannabis use in people with a cannabis use disorder, assessed by both biological and self-reported measures. With regard to conclusions, again, this was the first randomized controlled trial investigating this. It appears to be a safe and effective therapy at doses of 400 and 800 milligrams. The 400 milligram dose led to a greater reduction in the carboxy-THC creatinine ratio and a greater increase in the number of days of abstinence, but it appeared to interfere with sleep quality a little bit. The 800 milligram dose led to a lesser reduction, but still a reduction in the carboxy-THC creatinine ratio and a smaller increase in the number of days with abstinence. But the 800 milligram dose also reduced withdrawal symptoms and reduced anxiety. We need more randomized controlled trials to corroborate these findings, including those that use full-spectrum cannabis extracts, so that we can determine whether the products that the vast majority of consumers are using today, which are full-spectrum extracts being purchased over the counter, are as safe and as efficacious as isolated, essentially pharmaceutical CBD, and what doses of these products are going to be appropriate. With that, I'd like to thank you for your time and your attention. If you have any questions or feedback, please feel free to reach out to me at the email address below.